Hi, I'm Dr. Nighat. I'm an NHS GP. I specialise in women's health, and you're watching Angie's Book Club. She's amazing. You can put that down. We can talk about it.
Welcome to Angie's Book Club. She started already. I love her. I love her. I love her.
I'm telling her what to do. I'm so sorry.
This book, The Knowledge, has got nothing to do with taxi drivers. It is, in fact, I'm holding a coil. It is, in fact, the book that my mother would have hidden from me 20, 30 years ago. Please welcome to ABC, Dr. Nighat Arif. Now, you said earlier that I said it right, but tell me the different pronunciations.
So I'm Punjabi, and I'm from Pakistan as well. So it's actually pronounced Nighat, which is the Punjabi way.
Yeah.
There's also the Arabic way, which is Nighat as well.
Okay.
And would you believe it? It means to rescue. So on the day of judgment,
Wonderful.
Nighat will come down to rescue humanity.
There you go. And Angela is the heavenly messenger.
That's such a beautiful, like, what a combination to have, right?
I'll tell you where to go. Dr. Nighat, thank you. And you're all right with me calling you Nighat?
Yeah, of course.
Thank you for coming on to ABC. Thank you for this amazing book. Thank you for all of these instruments. Would that be the right way to call them?
Yeah, I mean, these are my props, I say, like as a jobbing doctor who's an educator as well at the same time. There's never a moment that I don't get stopped to ask, oh, Dr. Nighat, I want to talk to you about vaginal discharge. And I'm like, I've got something to talk to you about that.
Right. We're going to talk. Now, the knowledge, it is about predominantly the 3 stages of a woman's life. So from the start of menstruating, I call it puberty part 1, the fertility years, and then menopause, which I call puberty part 2. Part 1 you start, part 2 you stop. But there's lots that goes on in between. And what I love about this book and what I love about the way you talk, you don't pull any punches, you just say it as it is. You advise women and men, because if a single man is bringing up teenage girls, he needs to be equipped with this information. And you're also very, very clear you want to start, I'm going to say, a revolution.
I want to definitely start a conversation, and it's really almost in a way I relate to you so quickly, because you said this is the kind of book that my mother would have hidden.
Yeah. Because
when I was growing up, it was precisely, that was my experience. I started periods and I didn't know what was going on. Had a Punjabi mother, and, you know, God willing, the best of intentions for her, she just gave me this huge, big white pads.
Yes.
And she just said, these are it. And then that's it. And so I was left on my own. And it was only when I was about 15, so I started around the age of 10, that I realised there are pads with wings? Like, what?
Yeah.
That was a game
did you
changer.
have the belt?
No, I never had the belt. But I did have the... because I then was like, oh my goodness, I'm not participating in PE and I'm getting sores because they would chafe and rub.
Yeah,
and
yeah.
When you're a teenager, you're also going through that sweaty moment as well. And so when I started learning about women's health and menstruation and periods, I found it was mostly doodles and pictures, and they were just so graphic that I would hide them under my bed. And so when I was older, I was like, I want to see women who look like me, women of colour, firstly, women of faith as well. And so there's a lot of information around that.
Yes.
And also real anatomy, normal things, thigh gaps, you know, I don't have a thigh gap, but having thick thighs is completely normal. Having stretch marks is completely normal. Having a belly after having a baby because you haven't snapped back, you know, that's all completely normal. Having a hot flush is completely normal. So it's trying to have those conversations with the daughter, the mother, the grandmother, all 3 generations, with the men in their household, without shame.
Do you think it's a cultural thing that we hide these things?
I think it's a societal thing. The conversation around women has been that our bodies aren't ours. So breasts are hypersexualized, vulvas and vaginas are hypersexualized. If I look at my community, the South Asian community, we speak Punjabi. So English is actually not my first language. I speak Punjabi first. And then we don't have words. We don't have words for breasts. We call it chatti. We don't have words for vulvas. They're mostly swear words and derogatory words. So women feel so disempowered to even have that conversation about their bodies because it's not ours. It's siphoned off to everybody else. Having a baby, the amount of time still in 2023 when someone will go, oh, you're having a baby, and touch your stomach.
Yeah,
you're like,
yeah.
That's my anatomy.
Yes,
You're just touching.
Yeah.
But we do it, don't we? Because it's ours. It's our possession because you're having a baby. And I think that when it comes to the hypersexualization, there is a generational shame. So I'll tell you a really quick story. So the book arrived.
Yeah.
And it looks lovely.
It's beautiful.
On purpose, I didn't want vulvas and vaginas and anything. And I didn't want it pink. I was like, I don't want it pink. I want it to be sat on a coffee table that anybody could have. My father, who is the imam, was sat across the table over there. My mother was sat here. My father was just so happy that it said Arif on it, because there was that, my daughter, my Pakistani daughter, she kept the name and she's got Arif on it, you know, because I kept my maiden name. My mother, I gave it to her and she just went, this is so great. I'm so proud of you doing it. And she opened it to that page.
And then went.
She looked at me and she went, okay,
give that to me in English.
Which is translated as, you couldn't find anything else to do? My father, I was like, this is my life's work.
Yeah.
This is 2 years. My dad on the other said, I went to see. And my mother just went, it's not for your eyes.
Oh.
Divert your eyes. And I think that is just the epitome of the fact that where we are and where we have still time to go.
Yes, definitely. And you're very, very clear in the book that you want women to learn, own and understand their bodies.
Absolutely. And we need to understand that we go through transitions. So we are genetically going to go through this transition from puberty to the fertility years and also through menopause and beyond. Menopause is just not this...
It's not the end.
It's not the end, exactly. And I want women to thrive. And I also want women to understand that they are so much more powerful than sometimes leaders or societies or conversations leave them to believe. I'm reminded of a conversation that I had with a South Asian man. He was Pakistani and I used to work in Slough, and he came in constantly with high blood pressure. And I could never, Angie, manage his blood pressure.
Okay.
It came to the 7th consultation and I was looking at him and I was like, oh, actually, you're about 54 years old. So your wife must be a bit younger than you. So he said, yeah, my wife is 48. And I said, is everything okay at home? And he went, got the courage, because the rapport had been, and he said, actually, it's awful at home. My wife is having hot flushes and night sweats. There's no intimacy. I'm so stressed. And I said to him, well, other than just being a generalist, I do women's health, and ask her to come in because I wonder whether this could be menopause. Anyway, he must have cajoled her, got in the consultation a couple of weeks later. And she was perimenopausal. She was really having terrible hot flushes. There was a lot of anxiety and palpitations, and she'd lost her sense of self. So I treated her. And lo and behold, his blood pressure went
down.
And that's when it dawned on me, do you know what? We cannot have this women's health conversation as a gender conversation. Women are already invested. But if the woman is well, the household is well.
Do you know, I always say, I mean, we're probably of the same kind of generation where, and you know, culturally, we probably have some similarities. The man is the head of the household. I know it's an old saying, but it's something that we carry with us. But I always say the woman is the heartbeat.
She is. She's the soul. She's the spirit. She's the beauty. She gives the softness. She gives the, I would say, the humanity sometimes in a situation, because whether we like it or not, women are nurturers. And we have a saying in our culture as well. So you give a woman a bag of seeds and soil, she'll grow you an orchard.
Absolutely.
And that is, I think...
And feed the village.
And feed the village and nurture the children and look after the men. So for economies to thrive, for society to thrive, for cultures to have a better understanding, it starts with the investment with women and girls, and it starts with the knowledge.
And I'm loving the fact that there is a conversation now, and I'm going to say about menopause, a lot of things, but let's say menopause, that it's thriving. We're not whispering about it.
Yeah.
Being menopausal is not the end. It doesn't mean you're old. A very, very dear friend of mine who lives in the States was perimenopausal at 28. Didn't know what was going on, and she'd finished by the time she was about 35, 36. Didn't know what was going on, didn't have kids. Can you imagine at the time, and I'm going back about 10, 20 years, not being able to talk about it? That in itself adds stress.
Absolutely. I grew up in a mosque, so I would see lots of women at the mosque, and women talk in places of safety. And what they do is that they started having these conversations and talking about head-to-toe pain, but they never once mentioned hot flushes. And it's only when older Nighat became a doctor and started looking at the profile of the symptoms, because we were taught hot flushes, night sweats, a bit of irritability, and it's a phase, and then you're fine, and you go out and it's normal. And I'd say to women, I said to a woman from Dubai, do you get hot flushes? And she went, stand in the 50-degree heat in Dubai, you'll know what a hot flush is. And then it realized and it dawned on me that we as women, we give symptoms depending on the context, because the doctor's got cancer and other things to worry about. But also it gives women the ability to go, I want to have the conversation because this is going to impact me. But we're now understanding the long-term health complications on our brain health, our cardiovascular health, our bone health. And the fact that actually our sexuality, and I think we need to talk about this a lot more.
Yes.
Our sexuality doesn't just end in our 30s. We are sexual beings for the rest of our lives. And that is so progressive, but women enjoy sex. I can tell you as a doctor, and we need to celebrate that.
But I also feel having, please Lord, come out the other side of menopause, and we must talk about HRT because I never took it. We must talk about that. I actually think not having to worry about contraception, how wonderful. But women can get pregnant through the menopause, can't they?
In the perimenopausal phase, when you're still having periods, so perimenopause is defined as a time when you're still having periods and also menopausal symptoms.
Yeah.
And we think it roughly starts around the age of 40. But the interesting thing is the SWAN study in 2022, which is the only study done on ethnic minority women, shows that Black and Asian women probably go through that earlier, probably between 2 to 5 years earlier than their white counterpart. So we've got to stop thinking of this sort of as a numbers game and whether you're having periods or not. So we need to really focus on symptomology of the menopause. Menopause is defined as 1 year without a period. Postmenopause is 1 year, 1 day. And then you're postmenopausal for the rest of your life. Okay. And it's because of two hormones, well, three hormones, but we'll talk about two today, which is estrogen and progesterone. They fluctuate and they go up and down. And when that change happens, your ovulation can still be going. So if you're having periods and you're having menopausal symptoms, you need to think about contraception. But the interesting thing is that we also postmenopausally, although your periods have stopped, we're seeing a rise in sexually transmitted diseases. And I shouldn't laugh, but the concept is, well, I can't fall pregnant.
I'm not going to use contraception.
Women are sexual beings and, more power to them. So if you are, having more than one partner, then please protect yourself. And all power to you, but just use protection.
So much to cover, Dr. Nighat. You mentioned about 1 year period free, you are menopausal, you've gone through the menopause.
Yeah.
What if you have a breakthrough bleed at month 6 or 10 or 11?
So by that time, what I do is I go by my patient's symptoms. If you had no periods for 6 months and then you've had a bleed, then we look at what type of bleed it was. Was it a proper menstrual cycle? Was it just that you had a show? Was it a little bit? And then either you quantify that into go, right, we're going to reset the time. It's now 1 year from this period.
Right. Or
if it was a small sort of a breakthrough or a show, we say, do you know what, it was just a breakthrough or a show. Let's see whether you then have another 6 months of no period. And so that's where the doctor has to really be quite savvy. In regards to what if I don't have any periods at all, because Dr. Nighat, I'm on contraceptives. I've got the Mirena coil or I take the mini pill, etc. Then what happens? Actually, do you know what? Still, we go by symptoms alone.
Right.
So then the patient is like, but I want tests. I want to have a test to know whether I'm in the menopause. And this is where it's slightly tricky because the data and the research is actually really shoddy. So for women over the age of 45, there's a blood test that we can do, which is a follicle stimulating hormone.
Okay.
However, that can still be relatively normal because these aren't standardized tests and they haven't taken ethnic minority women into their context.
And we so need to go there.
I know. So women over the age of 45, I don't do any FSH blood test at all because they're not going to, we go by symptoms,
right,
regardless of where you are with your cycles. Women below the age of 45, you do an FSH 6 weeks apart. But amongst that, a very good doctor should be ruling out other conditions because the symptoms overlap so many other conditions. So you want to talk about thyroid, you want to rule out anemia, you want to rule out liver and kidney problems, you want to rule out type 2 diabetes. Because the menopausal symptoms, if you go from, like Angie, your head to toe, they're going to be so varied. You'll notice hair thinning, you'll notice brain fog, irritability. You'll notice, actually we see in Turkish women, tinnitus and a burning roof sensation. You might notice that your skin doesn't heal so well or an itchy skin, palpitations, a hot flush, night sweat. Amongst that, you get loss of self-confidence, loss of libido. Then you might get digestive issues, stuff that you could tolerate, you just can't tolerate anymore. Then you get a whole load of vulval vaginal symptoms, dryness, soreness, itchiness that doesn't go away, loss of labia, And then on your legs as well, you might get these pins and needles, or almost feeling like spiders are coming up your skin.
Yes.
And then also you might find that you're getting burning feet as well.
First thing in the morning, I can remember, I just used to feel, my whole body just felt stiffer than normal, trying to get out of bed and, you know, jumping out of bed. It just wasn't happening. And I just realised it was taking me longer to get out of bed. I felt really, really kind of seized up.
I'm getting there because, I'm 39. I'll be 40 in February.
Okay.
So I'm heading towards my perimenopausal journey. Being from an ethnic minority community, I know I'm going to be going there a bit earlier anyway.
Yeah.
I'm mindful of that. And so I just need to know, how can I prepare for yourself? And actually, one of the things that I could never understand when I was a junior doctor working in Slough, because I worked with a lot of South Asian communities in Slough, is that they'd always come in and go, "Sara kuch dukhda hai, sir to leke paira tak," which is translated as everything hurts from head to toe.
Okay.
Even the follicles on my hair hurt right down to my toe. And we would say, "Oh, that's depression," and give them antidepressants, or it's a lack of vitamin D and give them vitamin D. And then 2-3 years later, they'll come back, not complaining of hot flushes, still complaining of pain.
Yes.
Because actually we forget that between 20% of women don't get hot flushes. There is this sort of fixation that that's the only symptom. For me, and now I'm starting to say this because terminology is so important. You know, I'm a perimenopausal woman. For me, my first symptoms have been genitourinary syndrome of the menopause,
right,
which is vaginal atrophy later. And that's because I started getting recurrent urinary tract infections.
I read about that and I was shocked. It's not, I just thought, whoa, where did this come from? Vaginal atrophy is the thinning of the vaginal walls.
Yeah, so I've put some pictures in the book to describe this really carefully. So estrogen, as it starts to drop, this is very late term, but I essentially say your body prioritizes where it needs estrogen. Estrogen, I've now, over my decades of sort of studying this, I've said, it's like this lovely lubricating hormone. You need it. It has its fingers in almost everything. It looks after all the brain cells and keeps the neurons and the synapses firing off. It also keeps things around your heart and your blood vessels going. Your immune system uses estrogen as a modulator. Your gut uses it to allow inflammation to come down. And your vulva and vagina use it as well. We have a lot of naturally occurring coliforms in our vulva and our vagina, and we have naturally occurring lubrication as well. And we need that because it's a barrier between the bugs from our back passage and into our vagina. Because let's face it, you know, our sewage work is next to our waterways, which isn't great.
I like that one.
The anatomy hasn't been thought out well, but in some aspects it's thought out very well. But essentially, as you lose estrogen, you lose a lot of the strength and the laxity around the pelvic floor muscles. You also lose it around the labia, around the clitoral area as well. So if you look at this picture, so what I've done is I've shown, look, it's lovely and plump and healthy. Look at the plumpness of all these estrogen cells. And then it shrinks, it starts to shrink, which is the medical word of atrophy. But what does it look like on the outside? Well, on the outside, when you're younger and you've got loads of highly estrogenized cells, all those bugs are kept at bay.
Yeah.
But not only do we have our clitoris, but our peeing system, our urethra is there as well. So when you get shrinkage, you get dryness. So that recurrent itch that's not going away and you've had it checked and it's not thrush, well, it's going to be genitourinary syndrome of the menopause. And then bugs around the perineum and the skin here. If you've ever had an episiotomy, or you've had, God forbid, you know, a rape victim, or you've had trauma down there for various other reasons, then actually that skin becomes ever so fragile. So women who have had episiotomy find that they split really easily. Having sex means right down here, which is a posterior fourchette, that splits and it becomes very, very sore. And also you end up finding that your vagina shrinks a little bit and the clitoral hood shrinks. And you get these recurrent urinary tract infections. So women come and say to me, I can't climax the way I used to, Dr. Nighat, and I don't know why that is.
Right.
And I'm like, it's because you're losing estrogen, and so you've got clitoral hood shrinkage. And it doesn't happen overnight. That's a good thing. It happens ever so gradually. So we've got to think beyond estrogen as just being important for the menopause. When we're breastfeeding, in order to breastfeed, there's a really complex hormonal changes that happen, but we do drop our estrogen. So I'm now talking to women who are, you know, postnatally going, if you're going to breastfeed, your estrogen will drop. And that itch that you get around the vagina is not thrush. Like, we'll check it. But actually what we need to do is give you topical vaginal estrogen.
There are so many, like you say, ailments, I don't like that word, that overlap.
Yeah.
So like you've just said, you know, you've not got thrush if you're breastfeeding, it's because of this.
The lack of estrogen.
Right. But there are, and I think sometimes, and I'm going to say this, especially as women of colour, we don't want to ask questions.
Yeah.
And I want to talk about this. I'm sorry, I'm going all over the place here. I just want to ask you a question. Most of your illustrations are of black and brown women and black and brown women's parts, and they're majority hairless. Now, I know obviously to illustrate and to show the different areas of the vulva, the vagina and clitoris and back passage, you need to keep the hair off. What is your thoughts about women shaving completely?
Don't need to shave, don't need to do anything. I mean, on this picture, because she does have pubic hair.
Yeah, but because we're talking about, you know, bugs from the back passage. Yeah. And if you've got a hairy back passage, obviously women have to wipe down. But if you've got a hairy back passage, can't those bugs get in the hair?
No. No. Leave the hair. You don't need to touch the hair.
Because
the hair is your...
I don't know if it's a fashion thing at the moment, but... You know, when I go just to get the bit off my legs off, she goes, "Oh, do you want Hollywood?" And I go, "What's Hollywood?" A lot off. No, it's
Take
okay.
The whole strip. No. In my book, I was very, it was really important to show hair, and it was really important to show hair
around
here.
Yeah.
And actually, you're right. And in the places where I show how to do an examination, that's absolutely right. But we don't need to be waxing or bleaching or anything. As a doctor, I say leave it as it is. Some women do it because of faith and cultural reasons.
Yes.
So as a Muslim woman, this is where the faith aspect plays a huge part, because as Muslims we believe to be able to do our ablutions, which is 5 times prayer, then you need to get rid of all hair, because there's a sense of cleanliness attached to it.
Okay.
But actually, that's a faith argument.
Okay.
But on a scientific medical argument, no. If you want to be au naturel, be au naturel.
Okay.
It doesn't make any difference to me as a doctor.
Right. It's important to you to connect with women of your culture. So you speak Urdu?
I speak Urdu and Punjabi, although that's become really mixed now, because it's like now I jump between the two.
Okay. And you champion black women's health as well, don't you?
I do. And that's reason because actually I worked with a lot of black women. I trained at Barts in London in Tower Hamlets. So the majority of my women in Tower Hamlets were Somali and Nigerian, Ghanaian women, who, by the way, are just the most beautiful women. I can't tell you how amazing Nigerian women are. And with Nigerian women, I found a kinship because they're very similar to us as Pakistani women. And then I realized that actually, although women are women, and if I tell a woman something, you know, use vaginal moisturizers, they'll go home and they'll be like, you know what, Dr. Nighat?
Yeah.
She said, do this. And women share stuff. That's why I love doing women's health. But the other thing that I realize is that when we're clumped in together under the terminology when it comes to medical services as BAME, whatever that means, Black, Asian, ethnic minorities, it really frustrates me because I know that I will never fully understand the struggles of a black woman.
Mm-hmm.
That means I will always empathise. I fully empathise the struggles that black women have gone through. But likewise, black women will never understand the partition and the struggles of South Asian women. South Asian women is a huge diaspora. We have had a huge issue in regards to women's health and patriarchy. And also we've had experiments done on us unwittingly under the British Empire, just exactly like women have under slavery. So let me give you an example. This is a speculum.
Right. When you have your smear.
When you have your smear. I'll tell you a little bit about the history of this. This was actually, this used to be called the Sims speculum, and there's a different version of this one as well, but it's been adapted over time. But Sims was a white doctor on a plantation in America. And he used to look after white patients, and for plantation owners to have their black slave women healthy and well meant that they could get more productivity from them. So he was given a license to basically experiment on black women. Literally 3 black women have now we know about, and would use spoons and spatulas without general anesthesia and do experiments and also investigate them, and then use what he learned on white women. He is known as the godfather of gynecology.
Is that so?
So we've dropped the Sims.
Okay.
So, but we still have the anatomy.
Yeah.
So the reason I feel an affiliation with Black women is that not only have we whitewashed them out of the literal gynecological science that I practice and the equipment that I use in my surgery. So there's a level of infuriation that I have that the speciality that I do is literally built on the backs of Black women.
Okay.
The injustice of the fact that we still call him the father of gynecology.
Okay.
And then thirdly, the fact that now in 2023, we still don't have Black women represented, women of colour, but particularly Black women in our healthcare system pathways. The NHS pathways are very much veered towards a white audience who's able to navigate themselves around the healthcare. Now, if English is not your first language, if you have a neurodiversity, if you have a physical disability, a learning disability, a hearing impairment, a visual impairment, the limitations that you have are just slimmer and slimmer and slimmer. And then on top of that, say that you're a Black woman with all those intersectionalities or a South Asian woman with all those intersectionalities. Where do I go?
Yeah.
So that is why I felt I need to put that where I've learned my knowledge and not just keep it to myself, but share it, but also influence the clinical pathways, which is the work that I'm doing on the women's health strategy.
And I love the way that you share. You do not tiptoe.
No.
You do not ask permission. You just straight for the jugular. Do this, go there, ring them, get an appointment. I want to talk about this very, very quick now. If time allows. When a woman has a smear, and this is obviously inserted into the vagina, and then it opens up. Sorry, because it would be that way, wouldn't it? Because then you're
we'd use it. So we'd use it this way.
Oh,
so
right. Okay.
This is the vagina.
Yes.
So it comes in different sizes. So this is just one.
Okay.
One example before everybody looking at this going, oh my God, this is huge. But they do come in different sizes, and a good doctor should be looking at the size where you are, if you've got vaginal atrophy, if you've had trauma, etc. So what happens is we use good amount of lubrication.
Yes.
So lubrication here, lubrication here. It's all about putting the patient at ease. And then I say to the patient, I'm now going to insert this so it's smooth.
Yeah.
So it goes in. And this is the bit that can feel slightly uncomfortable, is when we open it.
Right.
And then we can then sort of stabilise it into the womb. And because the pelvic floor muscles will hold it, and then a light will allow me to see the cervix.
Right.
So the cervix is really important to look at because, I can take swabs. I can see any lumps and bumps on the end of it. And then this is how we do smear.
Yes.
Testing.
Yeah. So when you do a smear, you're taking the moisture of the cervix?
No. So when we're doing a smear, the most important thing is we're collecting the cells. So they are the cervical cells that we're collecting, and we're collecting HPV virus cells.
Okay.
So HPV, we've identified that the cause of cervical cancer is because of these changes that can happen. But the early changes is because of a virus, a family of viruses called human papillomavirus.
And these cells, they live around the cervix?
So they live around and inside, which is the little hole in the middle, which opens up to about 10 centimetres.
To allow the baby out,
which we know about. So it's getting the cells off the os as well.
Okay.
And so what happens is then we send that off to the lab and we look at it. And there are two things that we look at. One is we're looking for these HPV cells, and that just means we need to monitor you and not do anything else. And that's not because you've been promiscuous or anything like that, because the concept is that, oh my God, I've got HPV from a sexually transmitted disease. HPV lives around in lots of different areas as well. And then the next thing is that we look for any what's known as dyskaryosis, so changes within those cells that are there.
Right. Precancerous cells.
Absolutely. That's it. That's dyskaryosis.
Right.
So actually, having a smear doesn't...
I
know. I'm like so impressed.
Yeah.
So having a smear actually doesn't pick up cancer.
Right.
It picks up early cancer, which is why... I mean, the fact that we've got a free test available... which can then prevent you from getting, cancer is life-saving.
Yeah.
That's why having your smear is so important.
Absolutely, absolutely. Have you found that, I hate the word, but I happen, cancer seems to be everywhere at the moment. It used to be over there. When you were a certain age, you come into your sell-by date, your body's given up, and this was the exit. But I'm just finding a lot of young people now are getting it.
My own son actually got liver cancer when he was about a year old, and he had a liver transplant. I know. So the woman that you see and sat in front of you, you're like, oh, she looks so collected. In fact, I've had quite, and this is not a time to get sympathy. I'm not looking for sympathy because I'm a
share
doctor.
your experience.
But we are the sum of our mistakes and we are the sum of our missed opportunities. And I for a long time, I was in a very dark place.
Okay.
I trained to be a GP and I trained then to do women's health. And I was actually one of the first doctors. People will hear a lot about Health Hub soon, but many years ago, around 2014 and 15, I was one of the first that started up Health Hubs, hence why I'm working on the women's health strategy now.
Okay.
I fell pregnant with my second son. And I was really happy. This was a planned pregnancy. I stepped away from all that work, went off on maternity leave. But when he was born, he got jaundice quite badly. I mean, he was jaundiced when he was born, but it was very awful jaundice. I had a lot of friends and doctors who came to see me who said, it's breast milk jaundice. Don't worry, it's okay. And I thought, that's okay. I think that's what it is. But then he came to about 6 weeks old. I've got another toddler who's 4 years old at home. And then I've got my newborn. And then his wee and poo was changing colour. His urine was very dark, his poo became very sticky. And even though I was trying to recover, I realised that actually this isn't something that's normal. So he had a blood test and they said to me, his liver's failed. His liver's completely gone. We subsequently discovered that he had a rare liver condition and he needed a liver transplant. So you go into sort of like Dr. Mama Bear mode. And that's what I essentially did. I went into that mode and then I couldn't work as a doctor, obviously, so I found that a real struggle. I was not Dr. Nighat anymore. I was a mother with a chronically sick child who, if we didn't get a liver transplant, he would possibly die on the wait list. And the statistics at the time, they're better now because some of the work that I've done. But, 1 in 5 people die waiting on the transplant list. Black and Asian and ethnic minorities wait longer because we don't talk about transplantation.
Yeah.
And you need a genetic pool and HLA match, so that was a real difficulty as well. And so he ended up getting liver cancer when he was about 9 months old, 10 months old.
Good Lord.
So the only thing that we could do was to get a transplant. Luckily, we did get a transplant. 6 rounds of chemo, steroids, and now he's better. But for 3 years, I lost my life. I was like,
I don't want to imagine.
But I wasn't the doctor. So cancer, but he's away. He's amazing, by the way.
Good.
He's now living and thriving really well. He's 8 years old. He takes some medicine every day, and now he's in charge of that. We call it his Tic Tac tablets that he has because they're the shape of Tic Tacs. But I come from cancer as a parent and a lived-in experience with my child. And I come from it is the fact that we've got to see it as a chronic disease. The great thing about cancer and modern medicine is the fact that most people will actually do really well. So if we look at women's cancers, breast cancer, the majority of women, if picked up early, will survive their cancer and they will die of something else. The majority of women with breast cancer or even cervical cancer will have a whole range of treatments that we never had before.
Yeah.
And it starts with awareness and understanding and then trying to navigate that journey so that she doesn't just become the breast cancer patient.
Yes.
She's a woman.
Yes.
If Dr. Nighat got breast cancer, I would be horrified if I knew that, oh, she's a doctor with breast cancer. I'd be like, no, I'm Dr. Nighat who does women's health and, who swims and, is an idiot most of the time. So things like that. But I think that we've got to start thinking of it as, I would say, a chronic disease like, other chronic diseases that we manage.
Yeah. Are you okay?
Yeah, I'm fine. I'm fine.
Can we go?
I'm really sorry. I wasn't going to share that today.
No, thank you. I really respect that. Can we go through some of the stuff on the table? Yeah. Let's go to the lube because we've done because we've done this and you as you said you cover it in lube. So let's talk lube.
Yeah. So okay. I'm going to start with lube because things have moved on. But when lubrication was first brought out, lubes were mostly oil-based and they were actually made for the comfort of the man.
Okay.
Because the foreskin would find, especially if a woman is not ready or she's a bit dry and, and especially if you're having anal sex, because we can't assume everybody has vaginal sex, then the foreskin would either get pulled or split at the posterior fourchette.
Okay.
So, yeah, we were just like the second afterthought.
Yeah. Deal with it.
Yeah, deal with it.
I'm lubed, you deal with
Yeah,
it.
exactly. And then, actually, I would say thank God for amazing campaigners. So Sam Talk Sex is a person I would really advise you follow on socials, because we realised that women have their own flora that they need, and they need something that's organic but doesn't have parabens and doesn't have glycerin, because glycerin is going to feed things like thrush if you already suffer from thrush. So there's a couple of brands I recommend. I mean, I carry Yes, but the reason is because I personally use the Yes moisturiser.
Okay.
So we've got to think about lubes and moisturisers. So we moisturise our face.
Yes.
We've got to moisturise that bit of skin as well.
Yeah.
So moisturisers have a whole load of great stuff, but also hyaluronic acid, so that plumps up the skin. So things like Hyalofem or Yes Organics, which instead of the blue line has the white line. And by the way, I'm not a brand promoter for this as well. I get no money for this, but I'm just talking about it because this is what I've got. And then if you're one to having comfortable sex and you're approaching that life of around midlife and you're noticing that there is a change, then actually women should be applying a moisturiser inside them, because that's usually water-based, and then a lubrication on their partner, and that's known as the double glide or the double slide method, which I talk about in my book.
Yes.
And that makes sex so much comfortable. But we don't have these conversations with women. And I say that, we need to think about our pelvic floor. So vibrators and using pelvic dilators are really important, because it keeps the pelvic floor great. So prolapses and holding in your urine helps with that. But also with vibrators, it allows more lubrications of your natural lubrication. And sometimes you could argue without the need of a man.
I was going to say, I really want to talk sex toys with you, but I don't think this is the...
No. And I think we should have a sex talk with Sam Talk Sex. She's brilliant. Because
you said vibrator, and I went...
Why did you do that? I saw that on your face.
My mum. No, but you'd be surprised. That's an interesting one.
I felt like suddenly you looked at me horrified.
Yeah.
And you were like, what are you talking about? You're a hijabbed woman.
But it's important to talk about all aspects of women's bodies, including sex. Right. And I really, oh my goodness, time.
But just on that, I do get a lot of pushback because I talk about this, but I'm like, this is actually my clinical work.
Yes.
And we forget how important good, intimate healthy sexual relationships are. And the majority of people, men and women, who just wish that they could have these conversations because it brings them closer, it lowers their blood pressure, it allows their mental health to be better. But we have so much inbuilt shame. So your reaction is generational shame.
Yes, absolutely. Absolutely.
And I've had to unlearn that because I realised that once I started doing social media, the first people to come for me were my own community. Sister, this should be behind closed doors. Ooh. Why are you discussing this? This is haram. This is dirty. And then I realised, oh my goodness, the thing that I do behind closed doors, it's not dirty for you then.
Well, there you go.
The fact that I do a cervical smear or I insert coils and I give you your life back is not dirty for you then.
No, that would be seen as medical.
Yes.
Yeah.
But what difference is it if I am sitting in a room educating millions because who don't have access to healthcare?
It's got to be done. Can we talk coils?
Yes.
Because I was holding this when we first started rolling. Now, is this just a general coil? So and what's the difference between a general coil and a marina coil?
Firstly, this is the shape of coils. So it's like a T shape, but it doesn't actually go like that. It comes straight and there's the device over it that holds it. Coils are coils. Right. Okay, that's just a generic word. Then we split coils into hormonal coils, and that's your marina.
Is that the one that spurts off estrogen?
So progesterone. Progesterone. So
and
this
thins the walls.
This is a dummy version of the marina coil, and it's levogestrel on this. So this is a synthetic form of progesterone.
Yeah.
And what this does is it stays in there and it thins the lining of the womb, so you bleed initially if there's a lot of lining in there.
Yeah.
provides you contraception. And if you are, say, perimenopausal woman, this will provide you the progesterone component of HRT. So a little bit goes back into the bloodstream.
Okay.
And then the other coil, so if you split the coil off, is the copper coil.
Ooh,
so
okay.
the copper coil would have copper around the body of it.
Yes.
And the copper would allow that to just provide you contraception. So what it does is it stuns the sperm, but also being a foreign object, but it doesn't actually give you any hormones or anything like that. So your periods still happen. And with copper coils, your periods can become heavier as well.
Right.
But actually, again, my gripe with the coil is this is an awful shape for women. Our wombs are not a triangle shape. We have a 3D womb.
Yeah.
So actually what we need is a coil that is a ball. And there is a new coil that's out called the intrauterine ball, or the sort of ballerina ball coil, the ballerina ball coil,
Right.
which I'm really excited about, by two women who are Swedish engineers, who, if it's a ball, actually the data shows less bleeding and less pain.
And we want less bleeding and less pain.
Exactly.
Of course we do.
Exactly. So the coil has so many amazing benefits to it.
Okay. But you're just not into the shape of that.
I don't think, I mean, this was manufactured by men, again,
Okay.
not really
Okay.
thinking about women's anatomy.
Yeah.
So
okay.
I will hopefully at one point come and talk to you about a different type of coil, which is a uterine. Now you can get it in other places around the world. It's just not got the MRHA approve it in the UK.
Right.
But that's something.
Come on
exciting.
now. Let's.
Oh, let's talk about vaginal
let's
estrogen.
talk.
So this is vaginal estrogen. So there's a little tablet at the end. Can you see?
Yeah.
So this is topical vaginal estrogen. This is Vagifem. And what you do is you put it into the vagina and then you press the plunger and it gives you estrogen. This works locally in and around the vulvar and vaginal area by replenishing those skin cells with estrogen. And you can be on this lifelong.
Okay.
And this is just a little bit of estrogen. So do you remember I said vaginal atrophy happens?
Yes, that's
So
what you
this
could
is
use.
the treatment for that.
Right. Okay.
And it's really sort of simple. You can buy this over the counter if you're over the age of 50 or postmenopausal. It is known as GINA, or your GP can give you a prescription for it.
Lovely. Come on now. Let's
So
keep
this
going.
is synthetic hormone replacement therapy. So this is the ones that we hear a lot about. This is an oral tablet. Now, I'm a huge fan of synthetic. For the right patient, they work really well. So this has got estrogen and progesterone. It's ClearFem, and it helps with hot flushes and night sweats.
And we must say, as you say in your book, we must always say one size doesn't fit all. Everybody
Absolutely.
is different. So whilst you're a fan of that, somebody watching might say, well, I was on it and it made me
Absolutely. And also somebody who has a history of clots or breast cancer, family history, or various other reasons, a synthetic oral tablet of HRT might not be the best version for you. But, you know, like I say, some of my patients are on it and I manage them, and it's been unfortunately vilified as the worst at HRT, and this definitely causes breast cancer.
Yeah,
but this is where, I mean, it's moved on, but about sort of, you know, in the early 2000s, it was the synthetic HRT that the data was done on.
Right. See, I never took it and I'm still flushing. And my friends keep saying to me, Ange, why are you putting yourself through this? Just take it. But you said 2 words, breast cancer. So now it's in there.
Yeah. So it's really important to talk about that.
Yeah.
The first thing is that the hot flushes can, for some women, be lifelong and they will come and go. But your body is made to adapt and cope with the hot flushes.
Yeah.
So I see that you had your fan and you're wearing, you know, the right materials. You've got your water, your hydration, your mindfulness really plays a huge part as well. And so if you're looking at breast cancer, your risk of breast cancer, generically, if we look at the data in the UK, is 1 in 7. So me sitting here, let's just take me as an example. If I had 7 of me in this room, one of us would get breast cancer. And it is horrible, isn't it? It's absolutely horrible.
I don't want to hear it.
However, the management of that is that, well, we have loads of other risks. I could go out and cross a road and get hit by a bus.
I know, but here we go. It's my breasts.
Yeah.
Sexualized. Here we go again. Do you understand where I'm coming from?
Absolutely. Absolutely. And this is the comment. So I say to my patients, if that is your line and you say, breast cancer, that's the word, and that's my biggest fear, Dr. Nighat, and I don't want to go anywhere near that. Well, increase that risk or be associated with it, I will respect that. So I say to my patient, that's fine. Let's look at how we can manage your flushes otherwise, because HRT is not the be all and end all.
Okay. Look, there's lots of other things here on the desk. You got to come back. I very, very, very much, before you go, I want to touch on fibroids. Is it a fact? You tell me, are fibroids more common in Asian and Black women?
Yes, more so in Black women. We know that in certain age groups as well, up to 80% increased risk in Black women. So fibroids are a collection of cells, and they're known as leiomyomas. It's covered a lot in my book. And they can grow in different sizes. They can be in different places in the womb as well. And actually, we don't know why Black women, again, this is the awful data that's out there. We don't know why Black women get it more. And fibroids will come and go as well. You can get small ones and then not have a fibroid for the rest of your life.
I was told estrogen feeds fibroids. Is that correct?
So slightly. So we know that if you are more estrogen predominant, and this is where genetics plays a huge part as well. So we know that there are certain ethnicities which are slightly more so. It means that because estrogen feeds isn't the right words, but impacts on the thickness of the endometrial lining, so the lining in the womb. So if you have more of an estrogen predominance, then yeah, of course it will be. Weight is a huge factor. Remember, we produce a lot of our sex hormones, so like estrogen, progesterone, testosterone, through our fat cells. So if you are bigger, then your chances...
Sexier.
I know, sexier. Exactly. It's about weight in the right places, right? So if you are going to be on the slightly bigger side, then obviously we know, again, obesity, which is, I believe, a chronic disease in this country, that also impacts on your risk of getting fibroids as well. So we still have so much to learn, but fibroids are unfortunately the biggest reason why my clinics are so full, because it causes heavy periods, painful periods, anemia, which we don't think about. And women just feel absolutely exhausted by it. They struggle to get pregnant as well. And they come in going, I feel like I'm 6 months pregnant and I'm bloated. And, you know, the dress that I had planned, now I can't wear because my fibroids are reacting. And it is something I feel that we're not getting to the bottom of, unfortunately.
No. I was told I shouldn't have clinically been able to conceive because I had 8.
Wowzers.
And I had 2 children, one at 8'4", one at 9 pounds. But now through the menopause and the difference in my hormones, I've been told they're shrinking.
Good.
So, all right now.
All right.
Dr. Nighat, there is so much more to talk about.
I know. I need to come back. I need to do a part 2.
I do want to talk to you about sex toys. I really... No, I do.
Maybe you're not going to judge me. You can't judge me because your face was like, I am your sister.
This will probably be my healing. I probably need to get over it. Do you know what I mean?
We are both going to come out of our generational shame closet together.
Absolutely. Absolutely. Dr. Nighat is amazing. I'm still holding on to this coil. The knowledge, everything you need to know, and men as well, because if you're a single father bringing up girls, you need to get this book. Dr. Nighat, thank you so much. Thank you.
Thank you.